Now, without further ado, it is an honor for me to introduce our speaker today, Dr. Lilia Cervantes. Dr. Cervantes is a physician in Denver, Colorado. And Dr. Cervantes is also the director of immigrant health and professor in the Department of Medicine at the University of Colorado School of Medicine. Her background directly informed her commitment to becoming a physician, as well as her community service and research focused on promoting social justice and health equity. Dr. Cervantes' research is focused on improving person-centered care and clinical outcomes among documented and undocumented Latinos with end-stage renal disease on dialysis. Her research has led to a health policy change that expanded access to quality care and thus a better quality of life for people with kidney failures. Thank you so much, Dr. Cervantes, for being here with us today.
Thank you so much for the opportunity to share about my experiences partnering with patients, clinicians, and community health workers for the purposes of promoting kidney health equity. Next slide. For today, what I'd like to do is first describe some of our foundational team's research. And this initial research informed and shaped the community health worker partnerships. And then I'll describe 2 community health worker studies, and lastly, review some of the key considerations for those of you that are interested and motivated to build sustainable community health worker programs in your kidney community. Next slide. Okay. So what I'd like to do is begin by sharing some of our core thoughts. And these are thoughts that drive our team's work. Like many of you, we recognize that each of us comes from a unique background, a different place, family, and culture. And many of us, many people face social challenges and experiences, and these shape our lives. In the work that we do as clinicians, we encourage people to look beyond those individual perspectives on worth and entitlement so that we can begin to see how connected we all are, and so that we can cultivate humanism and empathy in medicine. Next slide. So a lot of what we see in terms of a person's health journey depends on the social challenges. So these are the circumstances. And how well we as clinicians are able to understand and address them with compassion. For example, someone with kidney disease can be, someone with diabetic kidney disease, for example, this can be a catalyst for premature death for someone that's facing social challenges like poverty and stress. Or it can be a silent and well-controlled lifelong companion. And so these social challenges or social determinants of health are the conditions that we are born into, where we live, work, age, and some of the larger social forces that shape our lives and health. Next slide. So I've spent the last 10 years using community-engaged research methods to understand some of the challenges faced by Latinos, communities with end-stage kidney disease. And there are some key challenges. Many Latinos live in mixed immigration status families. So this means that the patient themselves might be a U.S. citizen, but they might live with family members that are non-citizens. And so they might hesitate to have a clinician, home dialysis educator come and visit their home, or they might hesitate to bring family into the dialysis center setting or a nephrology visit. And this might limit family decision-making. Some patients themselves might be non-citizens, and so they might be excluded from healthcare coverage, and this means that home dialysis might not be an option for them, and transplant might be cost prohibitive. And so if they are also non-citizens, they also lack safeguards. So this means that they have to stay employed while receiving kidney replacement therapy. Next slide. So in addition to understanding these social challenges, there are some key kidney health disparities that informed our team's partnership with community health workers. So from the ESRD and other published research, we know that Latinos have a 1.3-fold faster progression from chronic kidney disease to kidney failure than non-Latino whites. This is important because pre-dialysis nephrology care, as many of you know, is associated with improved survival. So reduced hospitalizations, increased quality of life, and improved preparation for kidney replacement therapy. Latinos constitute the racial and ethnic group that is most likely to start dialysis with a central venous catheter. And this is important because central venous catheter use at start of dialysis is associated with a twofold risk of fatal infection. They're also less likely to receive recommended kidney replacement therapy, such as home peritoneal dialysis, be waitlisted for kidney transplant, or receive a living donor kidney transplant compared to non-Latino whites. So to develop an intervention that meets the needs of this community, our team aimed to understand sort of the context, meaning we wanted to understand the perspectives or preferences and needs of Latino patients, caregivers, clinicians, as well as the context of the people that provide care for them, so clinicians, the characteristics of the dialysis facility, and the policies that drive how care is provided for these patients. And I want to just mention that the body of research I'm presenting is primarily focused on Latino patients, but all of this can be adapted to other communities. And so we partnered with patients, caregivers, clinicians, and other partners, and we built a community steering committee. And this community steering committee met regularly and provided guidance on the research, the interpretation of the research, the shaping and development of our community health worker program and partnerships. And we continue to meet with them, and they continue to be involved in providing further tailoring of the intervention for other kidney disease communities. Next slide. We started this initial work by conducting several qualitative interviews, but because of time, I'm just going to describe two of them. In this first study, we interviewed 20 Latino patients with kidney failure receiving in-center dialysis. And we asked them about symptom management, advanced care planning, and then importantly, we wanted to understand their perspectives on those factors that improve their well-being and those things that are distressing. Next slide. So with respect to what promotes their well-being, they described supportive relationships, especially those with peers who share lived experience with kidney disease. They also described family and social networks as being important. They mentioned how feeling like, or actually increasing their understanding of their illness could promote personal well-being, because then they would feel more informed about their dietary restriction, how to tailor their cultural foods, as well as medications. They also described how maintaining a positive outlook as well as recognizing their own self-value is helpful. And with respect to the most distressing aspect of their illness, patients described feeling culturally isolated with their dietary restrictions, so not quite understanding how to tailor their traditional foods. And patients also described feeling frustration around communication. They felt they understood less because of the lack of culturally responsive educational materials and the lack of language interpreters for those with limited English proficiency. And then in the next study, we conducted interviews with clinicians, and this was to understand their perspectives on how social challenges influence the well-being of their Latino patients. And in total, we interviewed 30 interdisciplinary clinicians. So we talked to social workers, registered dietitians, medical directors, dialysis techs, and physician assistants. Next slide, okay. Clinicians described, and again, like with these two studies, I'm just describing a few of the findings, not everything. But in this study, clinicians described how the quality of care was sometimes compromised because of communication issues. So many, especially registered dietitians and social workers, talked about the lack of culturally and language concordant educational materials that they could provide patients. They described difficulty with phone interpretation because conversations didn't feel personalized. Patients oftentimes couldn't hear the phone, and passing the phone back and forth felt time-consuming. And they wanted in-person language interpretation, but oftentimes they were told by their dialysis facility that it was cost prohibitive. And then Spanish-speaking staff, especially those who had technical roles like dialysis technicians, talked about being asked to step into the role of language interpreters. And because of the power dynamics that exist in the dialysis facility, they felt compelled to interpret. Many of them felt resentment because they had to balance language interpretation with other clinical responsibilities and without any financial compensation. And many of them talked about how they oftentimes observed the clinical team skip patients with limited English proficiency for lack of time to provide interpretation. And then with respect to social challenges, clinicians described how their patients struggled with unreliable transportation. So sometimes transportation was late or they just didn't show up. Many of their patients face economic instability. They can't pay for their medications or pay for their clinic appointment copays or afford healthy foods. Sometimes patients' benefits were dropped because of late paperwork and they didn't find out until the transportation company didn't show up. And with respect to psychosocial well-being, clinicians described how many of their patients struggled with isolation. We also asked clinicians what they think would improve the well-being of their Latino patients. And they described a desire to better understand the influence of culture, attitudes, beliefs, and experiences, and this could potentially foster more culturally responsive care. They also talked about finding more time to provide personalized care, so to really develop that more personalized patient-clinician relationship. And then lastly, and most important, I think, clinicians described their perspective about the importance of support for patients from people with shared experiences. So these would be people like peers through peer support groups or community health workers that could perhaps have a more personalized approach in a way that's culture and language concordant. And so we brought findings from the 2 studies I described, as well as other studies that our team had conducted, to our community steering committee. We discussed several different types of community-type interventions for this population, and we elected to move forward with community health worker programs. We identified a community health worker program that had been developed for Latino patients with advanced cancer. And we liked that program enough that our community steering committee decided to tailor that one specifically for patients with end-stage kidney disease. And so I want to take a moment to provide, next slide. I want to take a moment to just provide a brief background on community health worker interventions. The very first community health worker program originated back in 1989. After the American Cancer Society highlighted poverty as one of the key factors that contributes to worst breast cancer outcomes for minoritized people. To address this, the American Cancer Society supported the very first program led by Dr. Freeman in Harlem, New York. And some of you might be familiar with community health workers. They're also called navigators, promotoras, health coaches, lots of different names, but they tend to be lay people who are culturally concordant and familiar with the community. In these first studies that Dr. Freeman conducted, he employed people who were culturally congruent, and they worked to sort of identify medical and social barriers to breast cancer care. And over his time conducting many of these studies, he was able to improve breast cancer screening rates, early diagnosis, and nearly eliminated disparities in 5-year survival. And so as for our team, we wanted to adapt that community health worker program I mentioned that had been developed for Latinos with cancer. And at the time, I had been involved as part of a team that developed that particular program, and so we began by adapting this. And so what I'd like to do next is describe 2 studies. One is a single-arm intervention, and the second one is a small randomized controlled trial, just to give you a sense for what our team has done, and because this has informed sort of the bigger picture of how community health workers can be involved and engaged in the care of patients with kidney disease. So for this first study, we designed a single-arm prospective peer navigator study, and our goal with this first study was to assess the feasibility and acceptability. We recruited a total of 40 Latinos receiving in-center dialysis, and because it's a single-arm intervention, all of them received the community health worker support. Next slide. So the community health worker for this first study met with patients about every 2 weeks with the goal of meeting at least 5 times over 3 to 4 months. And during visits, the community health worker provided support with advanced care planning, social challenges, diet education, and mental health support. As I mentioned, we recruited a total of 40 for this first study, and the majority were Spanish speaking. They lived below the poverty line, had a low-level education, and the majority had diabetes. And with respect to the community health worker visits, participants met with the community health worker a total of about 7 times over 4 months. And the duration of these visits was about an hour and a half, and the majority, or 2/3 of these visits, took place in the dialysis center setting, and about 1/3 of these visits took place at home. And when collecting qualitative feedback, all of our participants said that they desired long-term support, meaning they didn't want the community health worker intervention to end. They wanted to continue to have more visits. And I should mention, a lot of our patients talked about how oftentimes with their illness, they have adjustment to illness issues, you know, related to a vascular complication or something. And so they felt like, you know, these initial high frequency visits with the CHW was incredible because they were able to address some of the challenges that they faced, but they wanted long-term support that allowed flexibility for them to request additional support when they were going through a challenge. Next slide. We also used a validated measure to collect feedback from participants about how the community health workers helped them. The majority felt that the community health worker improved their quality of life, provided emotional support, helped them make important decisions about their care. They also stated that after the intervention, they tried to better understand their illness, ask questions during visits, and they felt more involved in making decisions about their health. We also interviewed clinicians and our community health worker, and dialysis facility staff shared that they observed an increase in the number of patients that began the process of kidney transplant. They also observed an improvement in renal therapy adherence, meaning those patients that were part of the intervention arm were skipping dialysis less often and not shortening their dialysis sessions as often. They felt that the added context about home life, so this is insight that the community health worker provided to the clinical team because they had visited them at home. Anyhow, they felt that this additional context about home was helpful in thinking more thoughtfully about how they could support the patient medically. And if you remember, the community health workers for this particular first study provided support with advanced care planning. However, we heard from both patients and the CHWs that it was difficult to engage in conversations about advanced care planning early on. They needed to wait until the 4th or 5th visit once they had established trust. And patients and social workers also talked about how important it was for those first few visits to really focus on the social challenges that were sort of competing priorities for patients. They couldn't take care of themselves because of the challenges they were going through. And so after that study, we conducted a small randomized controlled trial. And this one was conducted with recruitment of patients at 6 urban Denver dialysis facilities. We modified the domains or focus areas of the support group for this next intervention, and we prioritized social challenges. So this was number 1. And separate from support with social challenges, the CHWs were also providing support with communication, social emotional support, and patient-identified goals of adherence. And we decided to remove the advanced care planning domain. And so to support social challenges, the community health workers first screened patients, and then during that first visit, they asked patients which social challenge is most distressing. And then they would work to provide resources for that social challenge. To support communication, the community health workers provided in-person language interpretation when the dialysis team rounded on the patient, and they were also open to attending clinic visits with patients. And then to support patient-identified goals of care and adherence, the CHWs developed a very trusting relationship with patients. They used their skill set in motivational interviewing and patient activation to better understand the patient's goals and work towards those goals. And patients randomized to the intervention arm, I should mention, so they received visits every 2 weeks over the course of 3 to 4 months as well, so similar to the previous study. And our primary outcome for this intervention was patient-centered adherence, as well as secondary outcomes like quality of life, social challenge burden, and patient activation. We enrolled a total of 139 patients from 6 inner-city dialysis centers. These patients had a low-level education, health literacy, the majority spoke Spanish, lived below the federal poverty line, and half were insured by Medicaid. We assessed all patients for social challenges and found that a third worried about losing their home. Almost half sometimes or often couldn't afford to purchase balanced meals. And in the past year, a fourth could not get food, clothing, or a cell phone. A third could not pay for utilities or medicine. And lastly, because of lack of transportation or transportation issues, a fifth mentioned not receiving dialysis. With respect to patient activation at baseline, you can see on this slide that over half of our patients had a level 1 or 2. So at the top, 18% were at a level 1 or totally disengaged, and 35% are aware but struggling. And I want to just take a moment to briefly describe patient activation. This is sort of a validated construct defined as the degree of knowledge, confidence, and skill that patients have to manage their own health. It's a construct that is associated with self-management of chronic conditions, and it's measured using the patient activation measure, which includes 13 questions. There's very little published on patient activation in patients with end-stage kidney disease. But the thought is that similar to how patient activation is associated with self-care in other conditions, that there's a chance that highly activated patients with end-stage kidney disease might engage in more self-management and goal setting. So for example, a highly activated patient might engage in understanding more about transplant and transition from in-center dialysis to transplant or to home dialysis. And so CMS actually includes patient activation in 2 of the Kidney Care Choices payment model. Their aim is to sort of incentivize quality of care, and when patient activation improves, participating nephrology practices receive a capitated payment on the basis of quality measures like the PAM, or the patient activation measure, and it's assessed at baseline and then around every 12 months. There's very little research on the minimally significant or clinically significant improvement of patient activations for people with end-stage kidney disease. But at this time, the goal is sort of a 3-point increase at 1 year. And then I should also mention that in the small amount of research that is published on patient activation in people on dialysis, patient activation typically either stays stagnant or it goes down. And so in our study, here I'm showing you some preliminary data. In our study and among patients assigned to that intervention arm, there was a significant difference in the change in patient activation from baseline to a final time. It increased by about 3 points compared to our control group, which dropped by 3 points. And then I should mention, I am not going to review our other data right now because we are still in the process of analyzing all of that. So after these first 2 CHW studies, our team, our community steering committee, we decided to apply for additional funding to conduct a larger multi-site study of the CHW program to demonstrate its effectiveness. And our primary aim in this larger multi-site study is to improve optimal kidney replacement therapy starts. And so for this new work, we've partnered with Vuela for Health. You see some of their staff members pictured here. This is a Latino community organization in Colorado, and they have the largest number of community health workers. They call them promotoras there. And what's important about this partnership is that the promotoras, or community health workers, are already trained in community health worker fundamentals. They're service-oriented, they're empathetic, and they're culturally and language concordant. We're also very excited to partner with them because This is a nonprofit that focuses on Latino health priorities. So this means that they have been providing support to our community in the space of diabetes and hypertension. And so they are already hearing about kidney disease from our Latino patients and are invested in this. And then lastly, given new CHW and Navigator Medicaid payment rules in our state in Colorado, and also now federal Medicare payment rules, several health systems are beginning to partner with nonprofits to employ CHWs. And so many of you, next slide, so you guys might all be aware of the CMS changes. Beginning January 2024, CMS is providing reimbursement for CHW services. And so under that patient navigation, a CHW can provide an initial 60-minute visit and subsequent 30-minute visits. And this is for a large number of services, including self-advocacy skills, healthcare system navigation, emotional support, or to provide mentorship, support, and inspiration. They also implemented community health integration, and under this payment rule, if a social need is identified by a clinician, support from a CHW to meet that social need is also reimbursed. And then separately, CMS has also implemented this transformational policy around assessment of health-related social needs for people with incident and prevalent end-stage kidney disease. So the ESRD Medical Evidence 2728 form now includes health-related social needs assessment, including an assessment of housing, caregiver support, transportation, English proficiency, financial strain, food, and interpersonal safety. And for those with prevalent kidney disease, the ESRD QIP facilities receive points for reporting their facility commitment to health equity, meaning they have to attest to 5 different equity domains. And then beginning in 2025, there will be 2 reporting measures that will be added, including screening for social drivers of health. Next slide. And so our team has really thought about the key considerations for success of when implementing CHW programs in the kidney disease space. We've published 2 narratives that provide a lot of details, and I've put pictures of them here in case you want to pull them up later. But in these 2 narratives, we describe CHW characteristics as well as well-being, supervision, and training. So they're available for use, and just really excited to share that this is an important time to really consider using CHWs in the dialysis facility setting, because there is now Medicare provision, or there's Medicaid payment for CHWs working with people with chronic conditions like kidney disease. And so now I'm going to dive into some of these key considerations in the last few minutes. For those of you interested in implementing CHW programs. And next slide. And so we've thought about some of these characteristics of the CHWs and how to sort of help CHWs, or how to sort of help you think about how to implement these programs. So with respect to CHWs, they can be lay non-medical people. They can have a high school diploma. Best if they have some kind of shared experience. So they've maybe faced similar social challenges, or maybe they have kidney disease themselves or have provided caregiving to someone with kidney disease. You want someone that has cultural humility, so someone that's humble, self-reflective, language concordant, and prior experience in a service-related field like a nonprofit, community-based organization, or a church. Someone that has excellent communication skills and well-being, or empathy. And then with respect to, next slide, and then with respect to well-being, this is really important to think about patient load, because a large patient load, especially if they're working with patients that have high social needs, this can contribute to burnout. It can be hard for a community health worker to sort of provide resources to a large number of patients. And so it becomes important to give the CHWs flexibility to share when that patient load feels like too much, so that they can pause or consider hiring a second community health worker. The second thing I'll say is that sometimes CHWs, because they are culturally concordant with the community can feel isolated in the dialysis team. And so it's important to also build peer support for these CHWs. So maybe having like weekly CHW virtual meetings, and this can be between CHWs at different facilities. And then lastly, really important to sort of integrate them into the dialysis care team so that they feel like a valued member of the team and so that they can provide that context to the rest of the dialysis team. Next slide. And then with respect to supervision and training, the natural supervisor is typically a social worker at that dialysis facility. And for training, Medicare and state Medicaid agencies that provide reimbursement have set specific requirements for training. And so CHWs working with people that have a chronic illness need to have certification in that principal illness. And then separate from this required training, I recommend training in motivational interviewing and patient activation. And then they also need time to do some clinical shadowing with various different types of clinicians. And then other trainings that our CHWs have found useful include trauma-informed care and then palliative care and mental health care. Next slide. And then as I mentioned, we continue to receive feedback from our community steering committee. And so we've recently, been talking about how to further modify these CHW programs. And I just want to share some of their perspectives because I think it's really important. So for our large multi-site study that we plan to launch soon, our CSE has recommended that the CHWs actually focus that very first visit with patients on building trust and rapport. And maybe not engaging into whether or not they need support with a health-related social need unless it feels like a natural part of the conversation. Because from their perspective, once trust is established, it's that much easier to understand the social challenges that patients face and to provide them with support. They thought that if it doesn't come up during that first visit, that perhaps during the second visit, the CHW could gauge their interest in receiving resources for any social need. And then lastly, one thing they recommended is that for these visits, if at least one visit during the first few months could take place at home, that there's a lot of value in that, because it gives the CHW context on sort of the social support system a patient has, as well as helps the family feel more engaged in the patient's care, and it helps the dialysis team understand the context at home and how they can best support the patient. Next slide. And so now, as many of you consider these new and transformative policy changes from CMS, I think, in thinking about health-related social needs screening in the dialysis center setting, it can feel like a lot of extra work, especially for a social worker that might already be time constrained. And so utilizing CHWs, especially now that there's available reimbursement, might be a way to do that screening in a way that's also culturally responsive. A lot of our patients have expressed sometimes feeling uncomfortable sharing about their social challenges, but perhaps if it's someone that they trust, they might be more open to sharing about the challenges they're truly having at home and receiving support. And then lastly, what I'll say is with patient activation, it is an important measure. It's in 2 of the KCC models. And the beauty of having CHWs in the dialysis center setting is they can be trained in motivational interviewing and patient activation, and they can help patients connect their own values and self-care goals with action-oriented things and medical decision-making. Next slide. And so given our team's experience with CHWs and these programs over the last several years, we actually started developing a CHW kidney disease training program for community health workers, navigators, because it's a requirement by Medicare and most state Medicaid programs. What I want to just highlight is that the learning objectives for this training program were actually co-created by patients, caregivers, and clinicians, and our community health workers. So these are learning objectives that are inclusive of the things that clinicians think are important to CHWs know, but also what patients think CHWs should know. And then we have an incredible expert, Dr. Valverde, who's been involved at the state policy level in implementing CHW programs, and she's supervising this training program. And the last thing I'll mention about this training program is that we plan to provide it for free, totally for free, because we believe that cost should not, that this type of training should not be cost prohibitive for CHWs interested in this space and centers interested in having CHWs. So next slide, this is my second to last slide. So now with respect to future directions, as I mentioned, we're getting ready to launch a larger CHW multi-site study. For dialysis facilities, I see great value in improving the patient experience through implementing these types of programs, especially for these new CMS rules like assessment of health-related social needs and the inclusion of quality measures like patient activation. And then I'll just mention once again that this program can be adapted to other communities, other groups, and can be adapted for other individuals with kidney disease. So it can be used for people at high risk of kidney disease, like hypertension and diabetes, to help them with self-management. It could be used for people with advanced kidney disease to promote, to help them prevent progression to kidney failure. It can be used for people with AKI. So lots of different ways to promote and support health equity. And lastly, I want to just take a moment to allow our CHWs to very briefly introduce themselves. So Claudia, maybe you can say your name and maybe just a couple of things about yourself, and then we can dive into questions.
Yeah, hello. Thank you. Thank you for allowing me. My name is Claudia Camacho. I've been working with Dr. Cervantes since 2013. You know, I personally, I have my father was a kidney patient. He passed away a while ago now. I cannot do math right now. But that was kind of the reason why I'm really interested and passionate about this work, because I think we went through a lot of stuff that we could have, if we had somebody like me, we could have done, my dad could have done better. We have or the greatest community or our committee, starting that, you know, they also provide a lot of information to these studies. Thank you. I'm not sure if I know Olivia, it's on the call, but I'm not sure about Julieta, so we'll see. Olivia?
Can you see me?
There you go.
Okay. Hi, my name is Olivia, and I've been a health promoter for the last almost 16 years. And also my dad is a patient, kidney patient, for the last 5 years. So I know a little bit of what's going on, and I know that having someone that goes through the process can be a lot of help for the patient. So I'm really passionate about this program right now.
Very nice, Olivia. Thank you. Julieta, is Julieta there? Maybe not, right?
Claudia, what is her last name so we can find her? And
it should be Ruiz Llamas, R-U-I-Z, Llamas, L-L-A-M-S. She has some personal problems, I believe, so she might not be on the call.
Thank you so much for being here. And while Emma is trying to find her in the audience to promote her to panelists, I wanted to also kind of take this chance to thank Dr. Cervantes for the incredible talk, and we're grateful for Olivia and Claudia to join us today. And we'll open up for questions from the audience. I know that questions are coming in. And as we wait for some of the questions too, I wanted to start us off with a few questions, if I may. And the first questions I want to ask is that, what are your top strategies for addressing patients' health-related social needs? I know that Dr. Cervantes mentioned many different ones. And for example, could you share with us what have been some effective strategies for overcoming the cultural and language barrier to ensure that the patients understand their treatment plans?
The strategies, the initial patient navigation training that Dr. Valverde has provided for the patient navigation or patient navigators help a lot to develop strategies. Personally, I do listen to the patient, to the needs. Many times the barriers that they have, the social barriers that they have differ or are in the barriers that are preventing them to do better with the disease. So, we help achieve those or overcome those barriers, so that way, they can concentrate on their illness. And then we create that support, we create visits, we ask the patients, we schedule visits with the providers, and then we give that one-on-one support on the same visit, or try to coach them before visit, so that way they can talk to the patient, to the doctor, their real needs.
And Chow, if I may, I see a question in the chat that I'd love to respond to. The question about social workers being replaced. This is such an important question because it is something everyone is thinking about. I've had this question before. And our experience in these two studies, especially the second one where we were at 6 different dialysis facilities, and Claudia can speak to this. She worked very closely with a social worker, and there were 2 dialysis facilities where the health-related social needs were particularly high, like so high. And what was amazing is that Claudia was able to sort of support the social worker in that setting by providing added context about what the patient was facing at home. And the other really incredible thing is that Claudia had connections to a lot of the nonprofits in the geographic area of the high needs dialysis facility, and was able to sort of provide that warm handoff of not just understanding the social need, but connecting them to, or connecting the CDO to the patient, and then ensuring that that social need was provided. And so I don't see it as replacing, I see it as like sort of promoting and adding on to the excellent care that's already taking place, especially at these facilities with very high social needs.
Yes, that's correct. Echoing the same thing with what Dr. Cervantes says. At this point, I consider myself, or I on the dialysis center, I felt more like an, at the end of the intervention, they would consider me as an ally, right? So I was able to tackle or to get that cultural part that sometimes is missing through the social workers. And together, we were able to solve like a lot of stuff for the patient. If anything, I see a community health worker would be like the technician of the social worker, if anything like that.
And then just going back to the CMS description of the types of services they can provide for reimbursement, some of this was coaching, inspiration, patient activation. And so these are like sort of extra pieces that the CHW can do. And then some of the questions in here, who are the CHWs employed by? So right now, they are employed by our community partners, Vuela for Health. And because I have grant support for this work, they are essentially a sub-recipient, but they're fully employed by the community partner. And we're starting to see more of these types of partnerships between health systems and nonprofit community organizations because of the payment rules. How often do CHWs meet with patients? So as part of the 2 previous studies, the CHWs were meeting with patients every 2 weeks, but because this is a patient-centered program, we allowed for a lot of flexibility. So if a patient said, I need to meet with you twice this week, then the CHW was available. And I think this also speaks to what we heard from patients after the intervention, is that they go through sort of these waves of adjustment to illness, you know, especially when they have like an access complication or something is going on at home. So having that flexibility of saying, you know, you're in a good place right now, how about we meet once a month or every other month? And then there's patients that are perhaps more active with higher social needs, you know, every once in a while. So it can vary. And then, are they required to be state licensed? And so that's a great question. So there are some states that have expanded Medicaid either through waivers or through different mechanisms to provide reimbursement of or to sort of provide payment for CHWs. But at the federal level, Medicare does provide payment for the use of CHWs as long as they're connected to a healthcare system and clinician visit. And because of that, they are required to have certification. So for state Medicaid programs, they have certification requirements, and then at the federal level, they have to have principal illness certification. Are they required to be state licensed, and will they work only with Latinos? No. So I want to make that super clear. My research has focused on the Latino population, but absolutely not. This is a program that when I think about future directions, this has to be adapted to other communities. You know, it's initially the population that I've worked with that I sort of built all the foundational research on, but this type of program will be available to everyone and anyone. Are the CHWs assigned specific patients? You know, so this is tricky because the work that I've described is research, and so we essentially have certain eligibility criteria. And because it's research, we are upfront with patients. We let them know that they might be randomized to standard of care, which means they won't receive the community health worker support, and some will. So at this time, because it's research, they are assigned specific patients based on randomization. But when I think about future directions and implementation in the dialysis facility setting, I think if you know, as long as the CHW is working closely with the social worker can guide which patients might need the most support. And again, that's based on social needs or, you know, other social challenges that the patient might be facing. Sorry, I'm scrolling back because I'm realizing I'm looking at just the last questions. Where can you find out more information? So we are in the process of developing the CHW CKD training program. It will, again, be free, and we're thinking right now about where we could house this. And actually, that's a question I'd love to pose to this group. If you have thoughts on where this training program can live so that it is more available and easier to implement in your dialysis facilities, please let us know. Right now, I'm at the University of Colorado, and our team is building a team website, and we plan to have it freely available there. But if there is a website that you all tend to use or that you think would be more easily available, please let us know. We'd love to have this training program there. We have those 2 narratives that I described published that describe the CHW programs as well. And then the last study that I showed you, that's the one I described patient activation for. That study should be published in the next 4 to 5 months, and then that one will provide more context and characteristics and information about the CHW program.
There is a question about how do you go about helping undocumented patients? What are some of the resources? We are in Colorado. I think we are kind of lucky. There's a lot of resources. For dialysis patient transportation is a huge barrier. We are fortunate that our RTD, the public transportation company, they offer access a ride, which is, they don't ask for anything. There's like a $5 or $6. Actually, fares went down this year, but it's like a $9 round trip for dialysis. And they go and pick the patients, outside their home, and they bring it. There's also like food. We have an organization that makes kidney-friendly food, like Project Angel. And they sign up the patients and they get food delivered to their houses. So things like that. The most difficult part are housing, and housing will be the most difficult, because none of undocumented qualifies for housing. But we have a bank of we have all kinds of resources at the same time to choose from.
The thing I would add is that we do have 2 publications that illustrate a U.S. map and illustrate where undocumented have access to standard dialysis, also where they have access to transplant. And we will have a publication out soon that describes where undocumented have access to home dialysis as well. And this is through various strategies, either Medicaid or emergency Medicaid, or through legislation, but those 2 studies do exist. And to find all of this, what you can do is Google PubMed and then open up PubMed, and then you can type my name in there, Lilia Cervantes, and it'll pull up all the publications we have on access to care across the country for undocumented. You will see all of our community health worker and navigator studies published as well. The third thing you can do is email me. I'm happy to share my email. And then the fourth thing is I'm on X or Twitter, and I list all of our publications there as well. And every time we have a new publication, I put a link there so that people can access it. And so different ways to sort of get at this information.
Thank you so much. And definitely we will send out the post-webinar email, and we will include those links and post it on the NCC. And please feel free to continue to ask questions. We will collect all the questions. If we don't get everything together, we'll consolidate them into a Q&A. And for sure that we'll also post it and include it in our post-webinar email. And I want to thank Dr. Cervantes and Claudia and Olivia today for providing us ideas and best practices to improve health equity. And I want to take a minute and hand this to Lee, so that Lee will be sharing some highlights from this year's CMS Health Equity Conference that align with our topic today.
Thank you so much, Chow, and thank you, Dr. Cervantes and Claudia and Olivia, for such a great presentation. And like Chow said, now I'm going to talk about some of the key takeaways around partnerships and community engagement from the CMS Health Equity Conference this past May. But first, we want to do one final poll. So on the right side of your screen, you should see the statement, "I have ideas for collaboration opportunities with community organizations in my facility." So please take a second and rate how much you agree or disagree with that. And I really wanted to start with a quote from the conference that encompasses much of what Dr. Cervantes spoke about today, and that is, healthcare starts in the community and ends in the community. And the conference had really informative presentations around topics like targeted engagement, trusted community figures, and strategic partnerships that we'll touch on a bit today. And to ensure targeted engagement, it's super important to understand what the community's needs are to ensure the effectiveness of any initiatives. So for example, it's important to consider and ask what type of food your target population likes to eat and knows how to cook before starting something like a food drive. And community health workers, like we talked about today, are a great example of using community figures to really engage people where they are and where they feel comfortable. Health liaisons is another term that essentially means someone who can answer questions and address any concerns people might have about receiving care. Using local community figures as health liaisons, like barbers or pastors or other local leaders, is another great example of a way to effectively spread health information. And partnerships with like-minded organizations are a good way to spread health information as well. Using community-based organizations can help you connect with the local community. And one phrase to think about when working communities from the conference is listen, learn, and lead. So listen to the community, learn from the community, and empower the community to lead. It's also important to note with partnerships to make sure you're investing in the community and in community-based organizations before you ask something from them. This is very important in order to establish trusting relationships and build truly strategic partnerships. In closing, let's remember healthcare starts and ends in the community. And as we're all able to reflect on the insights that Dr. Cervantes, Claudia, and Olivia shared today and the lessons from the CMS Health Equity Conference, let's commit to actively listening, learning, and leading to empower in our partnerships with community organizations. Thank you all so much for your engagement today and dedication to building healthier communities. And let's quickly take a look at the poll results. It looks like there's a pretty big mixture of whether we have our ideas or not, but I hope that you've gained some inspiration today to find ways to connect with your community. Thank you so much, and I'll turn it back to Chow.
Thanks, Lee. And I wanted to just show this resource. So the link to the survey is in the chat, and we'll also send a post-webinar email. And this chat just want to show that this is the NCC Health Equity Change Packet. It has different change idea that can be implemented at the facility, including addressing health-related social needs. And just in closing, I wanted to encourage you all to share the best practices, and we'll be sending all the links, including all the papers that Dr. Cervantes mentioned today. And we hope this session provides you with some action steps and ideas for change, as well as strategies to improve health equity. And thank you to our speaker, Dr. Cervantes, and thank you so much, Claudia and Olivia, for all of you here for your work to advance health equity in the kidney community. And once again, please fill out the evaluation survey where you will find links to obtain the CU credits. And we look forward seeing you at our next Health Equity Learning Action Network call. Thank you all so much.